Hi, this is a video lecture on the concept of perfusion, specifically targeting early and late pregnancy bleeding. The first thing I'm going to talk to you about is abortions and miscarriages. And one of the things I want you to know is that abortion, is according to the GT-PAL that you've learned in antepartum, is a loss that's less than 20 weeks. So anything less than 20 weeks is considered an abortion. Miscarriage is kind of like the nice term for it because of the negative connotation with the word abortion, whether it's elective or medical or spontaneous. Okay, spontaneous happens without any type of intervention. And then when you have a medical abortion or an elective abortion, sometimes it takes medication or some types of procedures. According to your PowerPoint, we're talking about there's like five of them that we're talking about. Complete and a complete spontaneous abortion is where the cervix is closed on exam. The patient reports the passing of like clots and tissues, heavy cramping, and bleeding that quickly decrease. Okay. And that just means, and then through an ultrasound, they can see that there's nothing left in the uterine cavity. There might be some like blood left over that shows that there was, something there. So that is a complete. A missed abortion is where the patient does report amenorrhea. However, on exam, the cervix is closed. The pregnancy doesn't develop, but nothing has passed out of the cervix. So that's where we bring them in and we have to induce this type of abortion. An inevitable is where there's heavy cramping, bleeding. There's been some passage of clots and tissue. The cervix is open. So basically, it hasn't happened yet, but it's going to. The next one is a threatened where the cervix is closed and then there is some bleeding that's evident. You could cramp or you don't have to cramp. It doesn't necessarily have to happen. But sometimes bleeding early in pregnancy is kind of common. So the fact that there is bleeding, but if it's accompanied by cramping and some other issues, then it becomes one of the other ones and not so much a threatened. So threatened means it could happen. And a reoccurrent one is where there's two or more losses that are documented in a row. So that would require some additional interventions. Spontaneous abortions are pretty common. About 15 to 20% happen less than 20 weeks. The peak loss of time for a spontaneous abortion is between 5 and 8 weeks, and most are due to chromosomal issues. 70% of losses that happen of spontaneous abortions happen before pregnancy is confirmed, usually like by an ultrasound. Risk factors include advanced age for both mom and dad, poor maternal nutrition, drug and alcohol use, the use of any type of teratogenic meds or teratogenic exposure, some maternal health issues such like diabetes is one. When you have uncontrolled diabetes, it leads to some anomalies, lupus, as well as uterine anomalies or cervical anomalies. So those could be some of the reasons for that. An ectopic pregnancy is considered an early pregnancy bleeding, and this is a pregnancy that occurs outside of the uterus. And the most popular place is the ampulla of the fallopian tube. However, it can occur in the cervix, it can occur in the abdomen, like near the intestines, as well as in the ovaries. The classic signs of an ectopic pregnancy is like pelvic pain that is more off to one side. Sometimes you might have shoulder pain, and that means that pregnancy or something is kind of pressing on that phrenic nerve, which causes that referred shoulder pain. So depending on what side it is, there could be some bleeding. There doesn't absolutely have to be bleeding. But a lot of times you'll see the beta HCG levels will increase, but they don't increase as much. And then ultrasound to confirm that that the pregnancy is not in the uterus, that it might be elsewhere. There's two ways we can treat an ectopic pregnancy, and that is medical with methotrexate, and that's if the fallopian tube or wherever is not ruptured, okay, or the pregnancy is progressing. So where it's not progressing, where that's medical, and that's a folic acid antagonist. So the pregnancy stops, and after time, it just kind of absorbs into maternal system. The surgical treatment is if the pregnancy is progressing more or the tube ruptures, and it's definite that it could be life threatening. So sometimes they can go in and just get the pregnancy out, but oftentimes they have to sever that tube, and then that tube is no longer working, and then you have to count on the other tube if you're going to get pregnant again. Now, there's a lot of reasons why an ectopic pregnancy happens, and it could be like some type of infection too. So if the tubes are scarred and the embryo cannot travel, that's probably one of the number one reasons why that might happen. Later in the pregnancy, you think you get through the first part of early pregnancy. There's two conditions that involve the placenta. It's called placenta previa and abruptio placentae, and both of these can be further complicated by DIC and shock, but we're not going to really go into that now. So normally, you know where the placenta is implanted. It's in the upper part because it's rich in vascular and it's rich in oxygen and nutrients. So when a placenta doesn't implant correctly, you got to ask yourself why. Okay, so as we talked about last week in class, how the placental site heals by exfoliation and leftover decidua, that is from the maternal side of the placenta. But the problem with this is when people have C-sections, which is the number one risk factor for a placenta previa, they go in and they kind of clean it out, whereas that it becomes like smooth and there's nothing for this placenta to grab on, so it's going to migrate down. Okay, so that's kind of like what it is. So it is an abnormally implanted placenta. It could be totally covering the cervix, it could be partially covering the cervix, or it could be really close to the cervix. Okay, I can tell you with a complete certainty that if you have a total or a partial placenta previa, you're going to deliver by a C-section. If you have a marginal or a low-lying placenta, you can deliver vaginally, but again, you're going to be monitored pretty closely. Because remember, the placenta isn't implanted correctly, so there is issues that could happen with that. Your PowerPoint just shows some pictures, and we'll kind of go over that in class. Again, the number one risk factor is a woman that has had C-sections or D&Cs, or kind of work on her uterus, like induced abortions and things like that. Excuse me. It's more common in older women, women that smoke, and as well if you've had a previous previa that puts you in that high risk category. One of the big things to remember for nursing wise is that it's painless bright red bleeding that happens, okay? Because remember, there's all those spiral arteries there. It's not attached, so anything could cause it to bleed. So that's why we don't do any vaginal exams. So if we're going to check a woman's cervix, we're going to use a sterile speck exam, a gentle speck exam, and look at it that way. So painless bright red bleeding, no vaginal exams, nothing in the vagina, quite frankly. So the therapeutic management is based on the gestational age. So it depends on how much is she bleeding, is she not bleeding, okay? So conservative management basically is kind of like watch and see. We might give steroids if a mom starts to bleed early in her pregnancy, like, let's say she starts bleeding at 24, 26 weeks. You try to delay the birth as much as you can. Home care versus hospital, it depends on a lot of factors. One of the things is that how compliant is the patient, how many times have they bled, how far do they live from the hospital, and are they at home taking care of a bunch of toddlers, because you really need to be home and taking care of yourself, as well as alerting your local fire department that you have a placenta previa, and that if you call 911 from this place, then you need to come quick. Okay, the women need to understand their risks and understand their diagnosis, and understand that their activity has to be limited in this situation. As far as inpatient care, we would like just monitor the baby daily. Always have an IV ready just in case she does have a bleed, and then again being ready for an emergency situation if it happens. The next placental issue is called abruptio placentae, and this is a normally implanted placenta. Okay, so where the placenta previa wasn't normally implanted, it was abnormally implanted. This one is normally implanted before the fetus is born. So what happens is an abruption is where the placenta kind of detaches from the wall of the uterus before it's supposed to, and what is like a clot that forms behind it. The severity depends on the size of the abruption. So women can kind of go through their whole pregnancy with maybe just a small abruption, but it's very, very dangerous, okay? So this is more painful bleeding, painful darker bleeding, and it depends. It can be from colicky pain to the worst pain in your life, okay? When a placenta is completely detached from the wall of the uterus, there's no oxygen and nutrients getting to that baby, so asphyxia and anoxia could occur. Sometimes if a abruption is bad enough, we will deliver the baby prematurely. So again, you have to deal with not only the issues of mom losing a lot of blood, but also and the pain, but also a baby that's premature that has to do the job of what a full term baby would have to do. We'll go over some of the different types of abruptions, but one of the things that you have to understand, and then we're going to be talking about in the hypertensive video lecture, is that um, the risk factor is hypertension, gestational or chronic preeclampsia. So if you have uncontrolled blood pressure, it leads to the increasing the risk of an abruption. Now you think about it. So here's mom's spiral arteries. Here's the baby and the placenta. So what happens is when mom has high blood pressure, vasoconstriction happens. So the vasoconstriction of the endometrial arteries that cause the placenta to separate. So basically the force that it has to get through causes the detachment on this side. Okay, cocaine, same thing, a big vasoconstrictor. Cigarette smoking, vasoconstriction. Multiple gestation, anytime you have more than one baby, it increases the risk for everything. Any type of abdominal trauma, so getting in a car accident, getting punched or kicked or anything like that, which we've seen unfortunately. Previous history of an abruption, any autoimmune disorder that causes any type of coagulations issues, then that also puts you at risk. Now, an abruption isn't always an acute event. It depends on the size of the hematoma that forms behind it, the clot behind the placenta. Sometimes it can be hidden. Sometimes you won't even see any bleeding, or other times you'll see just major hemorrhage, okay? In an emergency or an acute event, the pain can be sudden and severe, and that is like a complete detachment, and it's agonizing. It's the abdomen is board-like. You could pop a quarter on it; it'll jump up. Okay, tender, making palpation of the fetus very difficult. You can see on your PowerPoint, it talks about that bleeding isn't always seen, but it is if it's dark red, and it's also painful versus the difference between a previa. Uterine irritability. So you're going to look at that contraction pattern. It's not going to be just like your normal contraction pattern. You're going to see all this irritability because the uterus is not at rest. Okay. You can have back pain just because of blood in the vault, abdominal pain, high resting tone with an intrauterine pressure catheter. Remember, an intrauterine pressure catheter measures the millimeters of mercury. So if you have this high resting tone because the uterus is not at rest, you might suspect that something like this. You also might see non-reassuring signs on the fetal heart rate. You might see signs of shock on mom, or you may have a baby that has died. So there's a lot of things that we're going to talk about. We worry about the baby, and death can result from hypoxia and prematurity. So that's why if you have an abruption, you're going to start off at the hospital, and you may stay in the hospital until you deliver, okay? Because we're going to look at the baby. We're going to give the baby steroids. We might want to give mom magnesium, not only for her blood pressure, but also just to kind of maybe calm the uterus a little bit. If the fetus is at all compromised, or a maternal mom is hemodynamically unstable, then we're going to have to get that baby out. There's a test that we do. It's called the Kleinhauer-Becky. It's a KB test, KB. And that tells us if there's a maternal fetal hemorrhage. So we always do that blood test. D-dimers are another test that we do just to check on maternal hemorrhage, okay? One of the things too is that you want to make sure that you're constantly monitoring this baby. And abruption is a pretty scary thing. So you're continuously monitoring mom and baby. Monitoring signs and symptoms of shock, monitoring signs and symptoms of the fetus not tolerating the situation. The best intensive care unit is inside mom until it's not. Prepare for surgery. Make sure you have some IV access. Provide emotional support because they have no idea what's going on. They got 15,000 people coming in at them, and they don't even understand what's going on. The last thing I want to be talking about is postpartum hemorrhage. And that is 500 mLs with vaginal delivery, 1,000 cc's with a C-section. It is the leading cause of maternal morbidity and death. Usually that first hour we worry about. Up to 24 hours is the most dangerous time for a postpartum hemorrhage. Women die every day from postpartum hemorrhage, and that's why it's so important that we are feeling that fundus and looking at mom's blood pressure and the lochia and all of that. So that bubble hearts is very important. So we talked about uterine atony. In fact, in class we talked about uterine atony can happen for a number of reasons when the uterus is relaxed. So we know how the uterus goes through that process of involution, right? We know that it heals by exfoliation, but the reason why we hang Pitocin is to facilitate those uterine contractions so that involution can happen. Well, sometimes for a lot of reasons, whether anything that overdistends the uterus, anything that if a long labor, a big baby, a lot of fluid is going to make the uterus not know what to do. So afterwards, it's kind of like, am I supposed to contract? Am I not? So that's why atony is the number one reason for that. So again, it has to be down. A full bladder can also cause uterine atony because if the bladder is rising, it's decreasing the uterus's ability to contract. So that's another reason why we look at the uterus very closely right after delivery. Trauma to the birth canal and labor and delivery happens again. Hematomas, retained placental parts, we'll talk about some of this. And then there's some different placental abnormalities that I'm not really going to get into. But one of the things when you're talking about a fundus that is boggy, a fundus that feels spongy and not like a shelf, that's how I feel it, or you can't find it, or it firms up when you start massaging, it firms up, or a fundus that's located above and over. One of the things, that it is if you have excessive lochia, you have clots, all of that are signs that the uterus is not contracting. Breastfeeding can help, but also some medications. So I talk about in class, and we'll talk about this further in class. So as a hint for RN exit, as a hint for NCLEX, as a hint for our exams, that when you have a fundus that is atonic, okay, look in the question to make sure, has she voided? If she voided, then the number one intervention that you're going to do is massage, okay? If, for example, the fundus is atonic and it's up and it's off to the side and she has not voided but she's not bleeding, you need to empty the bladder first and then reevaluate, okay? The meds that we use, you're going to be talking about in clinical, but oxytocin, we know that we give that sometimes with the shoulder or right after the placenta, and that is the medication that helps facilitate uterine contractions to start that involution process. Methergin is the next line. We give that IM. However, it's contraindicated in anybody who has high blood pressure. Cytotec is misoprostol. You've heard about this when we were talking about special considerations. Cytotec is a medication that we use to ripen the cervix. Excuse me. We use it for postpartum hemorrhages. However, the dose and the route is different. So compared to 0.25 micrograms that are given in the rectum or orally for cervical ripening, we give 1,000 micrograms in the rectum for postpartum hemorrhage. And so it's like 200 microgram pills, so you can put 5 pills in the rectum, okay? And sometimes, and the reason why they do that, and you're like, why do we give it in the rectum? And the thing is, it's very close to the uterus. There's a lot of vessels, and it actually spreads pretty quickly. Prostin or Hemabate is another medication that has a lot of side effects. We used to use that only in medical induced abortions. But sometimes we use this as a last line. And it's called Hemabate, and it's directly given right into the uterine muscle, like especially during a C-section, or we can give it IM. It has, for example, it causes diarrhea and fever. So we used to have to medicate people with Lomotil and Tylenol, just because of the side effects. And they have, it's really messy too, because, especially a mom who's had a C-section is bleeding and gets Hemabate, and she can't even feel that she's moving her bowel. So it's a wreck. TXA is this new medication that we get. It's called tranexamic acid. They get 2 IV bags. The first bag goes in really quick. So this is a new method that we're using. And then there's your manual. Your bimanual exam is where you're actually putting your hand inside and then your hand on top, and you're kind of squeezing it, maybe to putting some pressure. There's balloon placement where it's almost like a tamponade where they kind of put pressure on that one side. Uterine packing, ligation of vessels, and then the last resort is a hysterectomy. And then there's some pictures of what the bimanual exam looks like, and then you can also see a picture of the bladder, how when it's full, it's going to displace the uterus. Anytime that you have a firm fundus and you're having this bright red trickling, constant trickle of blood, you should suspect that there's some type of laceration or some type of repair that wasn't done or wasn't done completely. So always consider that. And then the last, one of the last things too is like the hematoma that I've talked a little bit about. Hematomas are very, 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 very painful. Women, after they have a vaginal delivery, of course they're going to be in pain. Of course they're going to be uncomfortable, but it should not be the worst pain of their life, and they should be hemodynamically stable. Sometimes when a hematoma is so bad, they feel that pressure, that pain, and their blood pressure drops, their pulse goes up, it's rapid, it's thready, because they're bleeding into this hematoma. And what's happening is it goes into this loose connective tissue that wasn't sutured enough. So the top layer was, but it's still bleeding into this area, and it can go retroperitoneally, and you have to use like intervention radiology to kind of like, diminish this, or sometimes if it's small enough, you can use ice. But again, always suspect that if somebody had an extensive, like a third or fourth degree, or they delivered with a vacuum or forceps. Anytime you have an operative delivery, you usually cut an episiotomy. So I always, in the back of my mind, I'm always like, you know what, is she in pain? How's her blood pressure? Because she could have a hematoma. So that's why you got to turn them over and you got to look. All right. The other lacerations, we talked a little bit about this in tissue integrity. Know the difference between a first degree and a fourth degree laceration. And then the other thing too is placental fragments. Placental fragments are something, that's why you look at the placenta to make sure it's full and complete, just because it could leave. And if it's an open wound, this part is not contracting. So that would be one of the reasons for a subinvolution. That would be one of the reasons for any type of infection afterwards. Again, they might need a D&C. You should not be able to feel the fundus after like 9 or 10 days. And then the final thing, I lied, it wasn't postpartum hemorrhage, it's DIC. In DIC, I know that you've learned this in Nursing 209, but it's both a defect in coagulation and anticoagulation. We get DIC, or our patients get DIC due to hypovolemic shock. So they go into shock, so you know what the signs of that is. So it's a rapid loss of fluid, hypotension, tachycardia, tachypnea. So again, because it decreases perfusion, therefore it decreases oxygenation, decreased urine output. There could be some level of conscious changes, cool, clammy, all of those symptoms of shock and DIC. And the big thing about DIC is that you would suspect it when you have like bleeding from the IV site, bleeding from your gums, bleeding from your nose, bleeding from the placental side. So it's early bruises. Bruises are an early sign of DIC. So that happens with a vast amount of like a postpartum hemorrhage. And then, again, I lied, DVTs. Their presence is depending on location. Again, you're going to look at some swelling, some pain. It's usually warm or tender. It's usually unilateral. So we look at the legs postpartum just to make sure that there's no symptoms of that. We used to do a Holman sign where you used to bend the ankle forward, flex it, and then you would feel pain like here in your leg. That's your leg. But they say now not to do that because that could dislodge a clot and go elsewhere. Treatment depends on severity. Sometimes they do a D-dimer as a test that is normally done when you suspected DVT, but it's elevated in pregnancy already. So sometimes they'll do a magnetic resonance venography, where they can look at the iliac vein DVTs or left lower extremity or superficial, so all of those. And really just so that's why we put the SCDs on, the people that are immobile, people that are in a C-section, people that have a history are treated. But that is a whole nother subject, and that is it for this one. See you soon.